Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Joining me today is Jamelia Hand, CEO of Vantage Clinical Consulting. Jamelia advises healthcare systems, corporate organizations, and advocacy groups in their efforts to reduce the national emergencies of opioid addiction and drug overdose via strategy, consulting, training, technical assistance, and program development. Her areas of expertise encompass behavioral health, digital health and AI integration, compliance and accreditation readiness, program design and implementation, value-based care, and health equity. And she joins us today from Chicago. Jamelia, welcome.
Thank you. Thank you so much for having me. It's a pleasure to be here.
Oh, same. Thanks so much for taking the time. You know, we had a really interesting conversation in the lead up to this, and you shared your remarkable career trajectory that has taken you through just about every sector of substance use treatment, from direct clinical services to corporate private organizations, compliance to digital health.
Mhm.
I'd like to go back to the beginning. How did you get
Mhm.
started on this journey?
So my journey really my journey started with my dad. My dad in the 70s, he was injured during a robbery and he was prescribed opioids for chronic pain. And of course, this was long before we understood all of the risks the way that we do now, right? And over time, the dependence on his opioids crossed over into addiction. And like many, many families, we were just trying to figure it out in real time without a roadmap. So, what ended up changing my life or the trajectory of my career was realizing that every time he encountered a barrier, I wanted to understand the system in which that barrier existed. When he needed counseling, I became a counselor. When medications became necessary and entered the conversation, I went into pharma and worked with medications used to treat opioid disorder. And after he passed away in 2010 from an overdose, I helped to launch Narcan nasal spray nationally. So I really just followed the need. I wanted his need and also helped others along the way. I wanted to understand how people entered treatment. I wanted to master what keeps them engaged. I wanted to understand why the systems failed them sometimes, and that led me into compliance and oversight work in Illinois, where I was able to see the field from an entirely different perspective.
You are an amazingly and admirably dedicated daughter, Jamelia.
Thank you.
That's really amazing. You're now focused on strategic consulting for opioid disorder treatment and peer support professional training. How does this work build on the spectrum of experience you've described that you've gained across all of those experiences?
Well, so the peer support work is simply one of the current projects that I'm working on with my alma mater, Governor State University, who I absolutely adore. And I think that what what I do what I do now is really the intersection of everything that I've learned over the years. My clinical experience helped me to understand the human side of care. My pharma and business development experience helped me to understand the business of treatment. It helped me to understand operations, scaling, partnerships, sustainability, all of those. My compliance experience helps me to understand risk. It helps me to understand workflows and really what regulators are actually looking for. The digital health helped me to understand implementation and adoption challenges, which are some things that I have really sunk my teeth into. So with Governor State, specifically, I do workforce development work with peers who are currently in a certification program. And that has been especially meaningful to me because I believe that peers are becoming increasingly important to the behavioral health workforce. I really don't see us moving forward without them. They bring a wonderfully unique experience. They bring credibility, they bring trust, they bring connection, and this is what organizations need right now and beyond. But what I've noticed is that sometimes we bring peers into these massive systems without adequately preparing them for the realities of the workplace. So
Yes.
these are things that I cover in my work with peers. So for Governor State, I did develop their peer support workforce development curriculum, but I also provide supervision sessions, resume workshops, interview preparation, professional communication. I really want them to understand how treatment organizations work. And at the same time, these same organizations are rolling out these AI solutions and other digital tools, and again, often without preparing the workforce for these changes. So, a lot of my work right now is helping the organizations to bridge the gap between the people, the systems, and the technology.
Yeah, I do want to get into the operations side, the sustainability aspects
Hmm.
of this work. Before I do, I just want to ask you a question about some of the work you do, training peers and preparing peers and so forth.
Hmm.
Um, I'm assuming there's a pretty significant attrition rate among peers as they enter this work, and maybe there are some things that they didn't prepare for. Is that
Hmm.
a real issue?
I believe that it is, but I would not say that is due to lack of passion. They come in with a passion that is absolutely beautiful. Is they but some of them are new to their recovery. So the curriculum that I developed for Governor State University, it not only teaches them how to approach the workforce, but there's a recovery component. So they're also practicing self-care along the way. Because every day they'll work with a client that is whose situation probably hits close to home for them. And if they don't take care of themselves throughout that process, they could potentially end up, relapsing. And we certainly don't want that to happen. But it's usually not related to the passion, rather, the systems that they didn't prepare for.
Right. Yeah, no, that makes perfect sense. Before any formal business engagement, you evaluate treatment organizations using what you call a secret shopper approach, which I thought was very interesting. How exactly does this work?
Yes, yes. So I got that. I stole that from retail. I used to work for Marshall Fields, which is now Macy's. I used to work for Marshall Fields back in the 90s, and this was just prior to my coming into this field. But basically, what the secret shopper approach does is it allows me to start evaluating organizations long before we start working together or our first official meeting. So I might contact an organization as if I'm a treatment organization, a behavioral health organization that provides treatment services. I will contact them as though I'm a patient or a family member, but more often than not, a referral resource just trying to access the services that they provide because I do that at least a few times per week. So that work is never in vain. It's always a good thing for me to check in on the organizations that I refer to or that I'm thinking about working with. So I pay attention to everything. I pay attention to how quickly the phone is answered. I'm thinking about and what you sometimes hear is that that first question is about insurance. Sometimes they don't even stop to acknowledge that someone may be in crisis as they make this call. I'm looking for whether staff can clearly explain their intake process. Are they compassionate? Are they confident? Are they knowledgeable? I'm looking for how organized they are. And then I follow that workflow mentality all the way through the treatment process. If someone is seeking medication for opioid use disorder, does the organization explain what to expect from them? How are they preparing the person appropriately for induction? So I'm looking for the barriers that are hidden inside the process that the leadership may not even realize exist. And once I go in person, I observe the physical environment. I look at what's on the walls. I'm listening for how clients are spoken to. I'm paying attention to what's happening at the front desk. You can learn so much about an organization from that first 5 minutes of contact. And what I've taken from that is that organizations are are so heavily focused on the marketing and outreach, but they don't always examine what happens after that client or patient arrives in the office. And that's where many organizations can unintentionally lose people along the way.
Yeah, no, that's very smart. And when I used to do a lot of business marketing consulting work,
Mhm.
you're initially dealing with the C-suite, CEO, head of marketing,
Yeah.
and all this, and you get a certain story. But what
Mhm.
I'd always like to do is cultivate people at all levels of the organization, people at the
Mhm.
front desk and the back office, because then
Yeah.
you get all the perspectives, and out of that really emerges the true company culture, really what's going on, where the issues are, right?
Excellent.
So it's sort of the same kind of thing. It ultimately is sort of undercover work.
It is. I spent 13 years in specialty pharmaceutical sales in for medications, devices, and technology. And that is where I learned about the total office call and the need to speak to everyone,
Yeah.
everyone who is included in that workflow. And if everyone has a different understanding of how to deliver that service or even what the core values of that service is, it makes finding the issue so much easier, for me.
Yeah. I used to refer to it sort of as the Rashomon technique, where you get at the truth by comparing all the lies.
That is just, oh, that's so efficient.
Yeah. And by the way, if you ever wanted to go into undercover work, I think you'd make the transition very easily. Just so you
Well,
know.
look, we never know.
Never know. Never
We
know. You can
never
always keep that open. You have you have the experience and the core competencies, if you will. Anyway, when we spoke, you emphasized a core problem in the field, sort of like cognitive dissonance, if you will. Providers understand clinical treatment well, but often lack knowledge of the business of treatment, the
Mhm,
billing,
mhm,
compliance, revenue operations. What are the real world consequences when
mhm,
there's this gap? And what do you recommend providers do to fill it? What do you do working
mhm.
with providers to make them more aware of that?
Yes, this is the conundrum I often speak about, which is what I call the business of treatment and the treatment business. So
Mm.
I'll define that for your listeners. The business of treatment is the clinical care itself. It is the counseling, the treatment planning, case management, peer support, recovery support services, everything under the clinical umbrella. And the treatment business is everything that keeps the doors open. It is the billing, it's the regulatory compliance, the staffing, the workflows, documentation, policies, everything operations. So a lot of organizations, or at least what I found in my work as a former regulator here in the state of Illinois, a lot of organizations are clinically sound, but they're operationally fragile. And the consequence is that even good organizations, and I've seen this time and time again, good organizations create risk for themselves and frustration for their clients when they're not operationally sound. For example, I've I've seen organizations that have the passion, that have the people who care so much about the service that is being provided, but they struggle with documentation. They completely struggle with documentation. They are not they're not tracking and monitoring the right data. Most organizations, depending on their payer or profit mix, they could be 80% grant funded. And if they're grant funded, they have to track some data, some really important data and some outcomes. But the funding does not allow for anything outside of direct clinical care. So it doesn't include a data team, it doesn't include a training team. And these are the things that increase the clinical strength, but again, the operations can struggle. So this this imbalance or misproportion can lead to claims that are denied, compliance findings, financial instability, even staff burnout, and ultimately interruptions in care for the clients. And what I recommend is that providers really begin treating their operational infrastructure with the same seriousness as their clinical care. And when we have leaders that understand this work as well as the people doing the work, they understand their workflows, they know their numbers, they're tracking the outcomes beyond admissions, because that's the number that most organizations know without even blinking. They know how many admissions they have, or they know how many admissions they need. And if they invest in themselves in operational training, they can achieve clinical excellence. But it's not enough. It's not enough to sustain an organization.
Why do organizations struggle in adopting and adapting digital tools and these days AI? And
Mhm.
re- as a related question, what can be done, particularly working with leadership, to remedy this and promote adoption in their work, particularly in their clinical work?
So what I have found, and I'm not sure if you're aware. I used to work for an organization called Paratherapeutics. They don't exist anymore. However, they did successfully launch the first FDA authorized prescription digital therapeutic, which is basically software to treat disease. That's what a prescription digital therapeutic is. And I worked on the implementation side of the business. So I was working with providers to implement this new technology into the workflows. And so what I learned in that experience is that many organizations struggle because they just underestimate the emotional and the operational impact of change. This was a change management project, and leadership, they sometimes introduce a technology and they assume that staff will immediately understand the value of that technology. But and they will implement it because leadership says so. But many employees are anxious. We're just living in a time where they are apprehensive about technology. They are worrying about job security. They are concerned about learning a new system or even losing that human connection in care. These are some of the challenges that I've heard about in my work. And in behavioral health specifically, many of these organizations still have workflows that are built around paper processes. Can you believe that some organizations still don't have an electronical electronic record yet.
I can believe it. Yes.
So introducing, digital tools is not just a software project. It is a full change man change management project, and they need to understand their own workflows before they can introduce a technology, because a technology can improve a strong system, but it can also confuse a weak one. And so what leadership can do is they can really help their organizations by communicating early, long before a rollout. They can communicate clearly. They can explain why the tool is being implemented. They need to take the time to get staff buy-in. They need to make sure that staff understands that the tool is not replacing them. They need to share with them what problem it's solving, and it has to be a problem that the teams believe is a problem as well. It's not just a leadership problem, but a staff problem. And so when they involve frontline staff in the process early on, which is something that they should definitely do, they can make sure that people are using the systems for what it was intended and that they're using it daily. And they also have to ensure that training is ongoing, that it's practical, that it works for people who may be technology deficient. And they need to make sure that digital literacy is is considered. They need to make sure that it's connected to real workflows, and they need to acknowledge that adoption takes time, right?
Yes.
Um, because resistance is not always about the technology itself. It usually is about the uncertainty that comes with it. So we just have to slow down and talk to our teams and make sure that we're acknowledging their concerns and that we address those, so that we can have less resistance.
Yeah, bad habits are hard to break, whether
Absolutely.
whether it's using technology or if you have a hitch in your swing. you
Absolutely.
Very, very hard to break. And a lot of people, and obviously to some extent, not to paint with too broad a brush, it's
Yeah.
generational. And their position is, hey, if it ain't broke, I've been
Yes.
doing this for years and years. So it's sometimes a hard thing to get around. So I see
Yeah.
this all the time. Um, Last question. Tell us a little bit about your weekly LinkedIn in the field posts when you
Mhm.
started this. What are some of the topics
Mhm.
you cover, and how has the reception been? It's really a great project.
Yeah. Yes, well, thank you for that. It's so this post, and I publish every Wednesday. It's a post. It's called In the Field. And I started the post because I really didn't have a place to dump all of the things that I was learning in the field. And I knew if I was struggling or if I was faced with certain things that other people were as well. So basically, I I I want to capture lessons that are happening in real time across the organizations that I work with every week. So, in these posts, I share observations, I share challenges, sometimes I even share conversations that about breakdowns in the business of treatment. Sometimes I could be like workforce issues, operational blind spots, regulatory challenges, digital adoption struggles, or customer service, specific to the client experience. Prior to, I would say, no, just yes, just before or during my work in retail, I was a chef. I was a personal chef and a caterer. And so I am a Le Cordon Bleu trained chef. And so what that taught me is that hospitality belongs everywhere. And it's really important to me that the work that I do and the organizations that I work with put the client experience first and make sure that the client experience is driving the decisions that are made about the services. So one of the weeks in the field, I talked about outreach teams. I talked about outreach teams and how many of them are trying to build referral relationships, but they don't understand what's happening inside of the organization that they're targeting. And another week, I spoke about intake processes and how much can be predicted from that very first phone call, and even what you can accomplish in that first phone call when the focus is on the client or the patient experience. And the reception has been really strong. People view these posts frequently, and I believe it's because they recognize themselves in the
Yes.
stories.
Yes.
So a lot of professionals in this field, or at least what I would like for them to feel seen. I want them to want to be honest about some of the operational realities that we're all facing, not just the clinical stuff, right? I don't criticize any organization. The goal is to really help people think differently about the systems and the service delivery and the client experience.
No, I think what you're doing is important because so much of this work is unsung. So I think it's very, very valuable. But I have
Yeah.
to ask, because now that I know you are a trained chef, I can't let you go. Cannot let you go without asking, is there a Jamelia Hand signature dish?
So there is no signature dish because, again, I focus on the client. So it really is about what my clients want. Additionally, I was going to say, however, additionally, what I love to prepare are salads. When I was in culinary school, I was really good at sauces. So I love to make homemade salad dressings and to make sure that my family or clients get in those vegetables, or at least that those 5 vegetables per day, fruits and or vegetables. I think that's still within the guidelines, right? I'm not sure. They could have changed recently. But, I loved a good layered salad, and I commit myself to 5 layers or more with a
Okay.
homemade dressing. I love Mediterranean cooking. I love how clean it is, how fresh, how flavorful it is. So that's probably my favorite type of cooking. Um,
Okay.
but it really is about the client. I focus on their need to drive my decisions, and I love every minute of serving.
Oh, I see. So in other words, if I were to pay you a visit, the
Yes,
meal would be tailored to my particular
ab
taste and
absolutely,
interest. Okay,
absolutely.
fair enough. And I will say, if you ever find yourself down here in South Florida, given that you like Mediterranean
Yeah.
food, I discovered an amazing Mediterranean restaurant down here. Now, anytime we go to a restaurant, I have to justify going to a restaurant that's not this restaurant. It's very hard to do.
Well,
So
Charles, it sounds like an invitation that
it
I'm
it 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 very much is. Very much is. You're
Yeah.
gonna love it. And by the way, are you a fan of the show The Bear? Have you seen that?
I have, and I love I'm a I love the dysfunction of it all because
Yes.
as a consultant, I like fixing things. So I watch it with the intent of what I would do if I were in that kitchen. I already know what I want to fix.
Is that based in Chicago?
You know what? If it is, I'm not aware of it.
I think it might be. I'm going to have to go check that out. Um, Any case, Julia, I really do appreciate you spending the time. It's a great conversation.
Thank you. I appreciate it as well and hope that we'll talk again soon.
Oh, for sure. Today, I was joined by Jamelia Hand, CEO of Vantage Clinical Consulting. Jamelia advises healthcare systems, corporate organizations, and advocacy groups in their efforts to reduce the national emergencies of opioid addiction and drug overdose via strategy consulting, training, technical assistance, and program development. She joined me today from her HQ in Chicago. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.